Okay, so I think we will start. Those that are not here will join us on the way. All right, good afternoon, everyone. Greeting you from Cardiocare Multi-Specialty Hospital, Abuja, Nigeria. We are happy to be here. My name is Dr. Iseko. With me is Dr. Olalekan, Olaleye. We're cardiologists with Cardiocare Hospital. And today we'll be talking about evaluation and management of a patient with palpitations. And we'll focus a lot on the evaluation. So when a patient comes and they say they're feeling their heartbeat, what do you do? How do you approach it? So today we'll take it out, and in the next 60 minutes, I expect you to be thoroughly educated, your practices to be empowered, and please, if you have any questions, put them in the Q&A box. Also, look out in the chat box for a link to the WhatsApp group, so that if you have follow-up questions or need follow-up support with your care of patients, especially in internal medicine and cardiovascular medicine, you could ask us. So again, we're coming from Cardiocare, and we are happy to be here.
Thank you for giving us your time again. And our aim today and objective is to really focus on how to evaluate a patient coming to you with palpitation, because after chest pain, this is likely going to be the most common symptoms you will get. So we want to know, why is it important to know about this? That is it everybody that comes to palpitation with palpitation that has heart problem, or is it everybody that has palpitation that has mental issue, or that's fuel subsidy is distorted? So we'll be able to know what we'll see that will make you to know, oh, I have to send this patient to a specialist or admit or do one or two things.
Okay, so you see on your screen evaluation and management of, if you cannot see the screen, can somebody say they cannot see the screen? If you cannot see the screen, kindly type in the chat box. If you cannot see the screen, kindly type in the chat box so that we can just clarify that. But I think it should be showing well. Can you confirm that screen is showing well? Great. Okay, so we'll just go straight ahead. My name is Dr. Iseko again. This is Dr. Olalekan. I'm from Cardiocare Abuja. Cardiocare is a member of the Linear Hospitals, which consists of 3 hospitals. The other 2 hospitals are the Linear Multi-Specialty Hospital in Central Area, Abuja, and the Limi Children's Hospital in Wuse to Abuja, all doing great work in different fields of medicine. Together, we cover virtually all specialties in medicine. We serve as a private tertiary hospital system for the region. So this is Cardiocare. This is where we are having our meeting. We're on the last floor now of this building, and then we suspended some of the clinics just to have this meeting. We are a support and reference hospital. Our aim is to reverse medical tourism and also to propagate healthcare delivery and training. This is why we are doing what we are doing, to teach even from what we know, to help Nigerian healthcare. And we originally founded in 1982. So, Dr. Olalekan, what are the objectives of this presentation?
So at the end of this presentation today, we'll be able to know what palpitation is.
Okay.
Then we'll go through the possible causes.
Correct. Okay.
Then at the end of the day, we'll be able to know how to assess our patients, and we'll just give a little hint on what to do about the management. But the bulk of the presentation will be on assessing the patient and stratifying the patient to those that needs urgent and specialist care, and those that can be managed at our general outpatient department.
Okay, great. Just to let you know that the recording of this webinar will be on our website, cardiocare.ng/webinars, and you will get a copy of the slides in your email, the email you used to register. You will get a copy of the slides so that you can use it again and again. Please, if you're using it, do give credit to whom credit is due. That's all we ask. But please share it widely, let everybody get knowledge. Okay, so can you tell us something about palpitation? You know it's common.
Yes,
a lot of patients are coming around. But what does it?
Very common.
Yes.
You will see a lot of patients coming to you that, oh, I can feel my heartbeats, I can hear my heartbeats. But generally, when we talk about palpitation, is very common and non-specific.
Yes.
So generally, some say is this disagreeable sensation of awareness of your heartbeat or pleasant feeling of your heart movements or similar movement in the chest area. So people come with different description of what they think they have, which they call palpitation. So it is not specific.
Some may not be palpitations.
Yes. So it is non-specific. It is mostly benign because, like you said, many may not, because I've seen someone that after description, what the person was having was shortness of breath, which was described as palpitation. Some people have described that sense of discomfort, which you see in patients with myocardial infarction, heart attack, as palpitation. So this is the reason why we need to carefully and patiently ask the patient to describe
what it is,
what they are feeling.
So we're going to show you what palpitation is, so that irrespective of the language, because we are not English by origin, and palpitation, I mean, a normal English person will understand what palpitation is. Yorubas will say, I am ninja. Other people will say, doctor, it's like I'm feeling fear, I'm feeling afraid. So some people describe palpitation as fear, that they're just feeling afraid of something. If you not rightly describe that, you may not know that they're trying to tell you that they are feeling palpitations or they are feeling. But it's important to note that palpitation does not always mean heart disease.
Yes.
And even though palpitation may be very bad, it does not mean that there's very severe heart disease. Where have I gone? Okay, so by definition, palpitation is sometimes defined as maybe rapid heartbeats. What are the other definitions?
So some people describe it like there's a rapid beating in the chest. Some people describe that they feel this heavy force or heavy thump in their heart. Some people say, doctor, it's like my heart is skipping, or I felt like for a second the heart paused, and I now felt a very strong contraction. And some people just tell you they feel like butterfly, flip-flop, or fluttering. Or some people, like you said, they are just like being that state of being afraid, being anxious, like as if something is about to happen. So these are different things that people can describe. And when we go forward, we know how we can use some of these symptoms to be able to narrow down to what the possible underlying cause is. And like Chief said, mostly, I think the reason why most people come with this to the hospital is that once they feel this, they think something is wrong.
Yes, and sometimes there is really.
Yes.
There is. One of the things doctors need to be careful about is to tell a patient that, don't worry, there's nothing wrong with you. It's in your mind. Whenever a patient presents with palpitation, even though a large majority of them may be normal or may not be benign, it is important that you investigate and do the right thing, because it can be life-threatening. Very, very important.
And we should not forget, we will also mention it, that a patient may also be having serious underlying heart rhythm or structural abnormality, and there will not be anything. And we saw a patient like that just last week in the clinic.
We see so many people that come without any serious symptom. Okay, so we know it's very common. Like, what do you think, sir?
It is in general practice. After chest pain, shortness of breath, palpitation is the most common. But to the cardiologist, after chest pain, palpitation is the second. And they're definitely, like with most of the conditions, it was difficult getting a nationwide data from Nigeria, but we have different studies from. But this is a US,
and that is where people are going to the hospital more. In Nigeria, a lot of people may have palpitations and not go to the hospital for years. And when they come, we now find out they do something significant.
So there, 60% of their outpatient visits
were for palpitation,
which is very large. Huge, 60%, and admission rate is as high, 1 in 4 of them will be admitted due to one reason or the other. And like I said, after chest pain, the next thing is palpitation. So it is very, very important topic and a very, very important symptoms to study and to identify. And when we look at that study, when they look at the causes, just they look at about 190 patients, they find out that about 43% of them had cardiac issues.
That is very high. That is very high.
That's almost half.
Almost half of the people. So it's important to not wave off palpitations as if it is nothing or it's in somebody's head. There are several reasons why you can have palpitations. So I know that there are at least three or four. Or when the heart rate is high, too fast, or too slow. When it's beating abnormally. Sometimes it is just a heightened awareness of one's own heartbeat, like anxiety.
Or an abnormal sensation, abnormal perception of a normal state reading.
Then what we call an augmentation of myocardial contraction, which may be either physiologic or pathologic.
Yes.
Some people will say they have palpitation, they come, they are really worried, but the palpitation is after sex.
Or exercise.
After exercise is when they are afraid. When they are watching horror films, they have palpitation. That is physiological augmentation.
When I tell my patients, sometimes I said, I will even be worried. If you have gone through all this and your heart rates had remained normal, that's just the normal response of the body to those situations because of maybe some stress hormones that are released at that time, that it will be abnormal for you to go through that and your heart rate to remain normal, then I will be worried.
Okay, then there is pathologic augmentation. Yes. Typically, when the heart is big, preload is higher, the heart has to pump more, it has to pump more forcefully, and typically the heart muscle has extra because it has to become bigger. So some of them now start having abnormal beats in hypertension, in valve disease, and different other structural diseases. So this is essentially how it comes. So, like you already mentioned,
the causes,
cardiac and psychiatric are high.
Yes.
Occasionally, we take psychiatric above cardiac.
Yes, and it is good to note here that the fact that someone had maybe some anxiety, depression, does not mean that there may not be a coexisting cardiac disease. So before you say, oh, just go, there is nothing, please make sure that you have done a thorough assessment in terms of history and investigation, because not even in our environment only, even in places where everything is working, they still miss some of it that have been categorized as having psychosomatization. It is just in your head, there is nothing.
And I have had a patient who has had several psychosomatization. Every day, one thing the next. And one day she came again. If not for the protocol, we repeated it and we saw real abnormalities. So it's important to realize that this could coexist, and up to 16% will be idiopathic, meaning we may not find
nothing
any
after all investigation. We will not be able to find anything.
Okay, so this is essentially what we are saying. Reading disorders are the most common.
Yes, they are the most common.
You know, and then
about 40% is structural disease, taking about 3% of the.
And then it could be mixed.
Yes.
People with structural disease are also more likely to have
arrhythmia.
Exactly. So that is important. So can you talk to us about these independent predictors of cardiac etiology?
When they went through those group of patients, they found out that those of them that are male, people that have had past history of a heart condition, people that their palpitation lasted longer than 5 minutes, and people that the heart rate at the point of assessment was irregular, were likely to have an underlying cardiac pathology as the cause of the heart failure. So the more of this that you find in your patients, so the person coming to you is a male, has an underlying heart disease. When you examine, you can find some irregularity. The chance that the palpitation is due to a cardiac problem is very high. So the more the number you have here, the higher the chance.
And the reason is simple. It's not really because males may have more or less. It's because women are more likely to come to the hospital as soon as they feel something.
Presents earlier.
Whenever a man finally gets to the hospital because of palpitation, something has thoroughly gone wrong.
It is very bad.
So it's quite important. Also, it's important to note that if people are having palpitation episodes lasting longer than 5 minutes, it is either truly abnormal or it is truly anxiety. It's truly nothing. So it's two ends of the spectrum that will happen when you have long breathing. So there are so many cardiac causes.
We don't go.
No.
Each one of these is a webinar. So
exactly. But one of the ones we'll talk about very importantly is hypertension. Hypertension is extremely common. And so a lot of times patients with hypertension may have this coexisting. This is why as cardio care and as those following us in cardio care, you will know that we insist that everybody presenting with hypertension should have a full evaluation, ECG, echo as part of it. Don't just give them drugs, don't just check whether their blood pressure is fine. Also make sure that they do not have any underlying issue, because you can be controlling the blood pressure without treating major things.
And another thing I want to point out is, when most of the time when we talk about arrhythmia, people always think of the very fast.
Yes.
The slow arrhythmia too can also cause palpitation. So people with advanced AV block, people with sick sinus, which we have seen.
Yes.
I remember even the Caucasian we presented that had that sick sinus syndrome. So all of them can present.
Even complete heart block. But the heart is now very slow. They are now feeling each beat. So it's very important to evaluate properly all these cases. So just a minute. Okay, now psychiatric causes.
So this is where we have to bring our brothers in the other departments in, because we need to patiently look at these patients so that we just don't generalize, because most of the time when you have hypertension, do you have this? It is in the mind. So we need to patiently look at this and be able to identify which of the condition, so that we know how to.
And there are quick screening questionnaires you can use in your clinic. So you could have quick. So do you ever have a situation where you have short bouts of fear, of panic, of excessive sweating? Is there someone that has died recently around you? You know, is your family life or your social life going well? Those are questions we need to ask really, to really exclude some of this. A lot of patients that I see break down crying. They came with something and they start crying in my office.
Then I noticed that when something happened around people, maybe somebody died in the office, somebody slumped, for the whole of that week,
everybody will having palpitation.
So you know that some of those are just panic attack, anxiety states. And when you see some of these in younger people, repeated visits, multiple symptoms that cannot be tied together. So this will raise. So these are the group of patients you want to ask the psychiatrist to also evaluate, so that, like we said, we don't want to miss some people that they really have some serious cardiac issues under the guise of, it's due to.
And we also don't want to miss people that have serious psychiatric issues.
Yes,
because and then whether both of them may coexist. Okay, the other issues, drugs, aminophylline. Now, just a quick one, as much as possible. I think we've done asthma before, but let me just emphasize. As much as possible, aminophylline should not be a routine drug that people should use for asthma. Franol, theophylline, all those drugs, ephedrine, should not be drugs you use routinely. There are proper categories of that, but not aminophylline. And this could really be very important including oral salbutamol. Some people still use oral salbutamol to treat asthma, unfortunately, and those are things that may worsen all of these things. Now, some of these are agbo and herbal medications.
They contain some of these. You don't really know what they put inside.
And some of the drugs that we are calling nutritional addition. So I've had patients that come in, they had just started and they bought something very expensive. I told them, unfortunately, they have to stop. Because after they started 1 week, 2 weeks, the palpitations were unbearable.
Many of them contains a lot of stimulants.
On
that different.
So it's very important for us to look at these causes.
Energy drinks.
Okay, so there are also other things, vasovagal attack, systemic skeletal contractions. So it could even be just systemic.
And some people with all these that posted, what you just have is this submammary pain due to just some neuro problem there. So which is not really,
which some people say it hooks them. It just feels like a hook like that. Where you feel so just a neurocirculatory asthenia that happens. Okay, so how do we evaluate, sir? Can you tell us something about evaluation? Because that's the main idea for everybody.
So the goal and the main aim of evaluation is to identify whether there's a serious life-threatening arrhythmia or underlying heart problem or not. Because like we said, it is not all palpitation that is due to arrhythmia. And there are so many fatal arrhythmia that will not have palpitation.
Very fatal.
So the main aim is to determine whether this palpitation is caused by life-threatening arrhythmia or cardiac problem or not. So if that is the only thing you can achieve, we have done a very excellent job. Okay. Then when you discover, okay, it is arrhythmia, you want to see and prevent other, like if a patient has atrial fibrillation and want to prevent stroke in them, then you want to know, does this patient need a specialist consultation or is there a need for admission? But that will really rely mainly on how good you are able to do the number one.
Exactly. I've seen patients that came in palpitation and they had very severe atrial fibrillation.
We've seen a patient that came with palpitation, and by the time we did the ECG, it was supraventricular tachycardia. The heart rate was about 180.
Wow. And if that person does not come in, or he's assumed that, look, it's just your mind, go and rest, go and sleep. You know, things could be really get fatal. Okay, so so the approach essentially is to have a good history, examination, and then evaluate. You know, generally just the basic things that we have done. So what are the key things in the history we're looking at, sir?
So you want to ask the patient this important question: the character of what the person is feeling. Okay. So you may sometimes ask the patient to maybe clap or maybe just tap. Okay, what do you perceive? Okay, it's like this. So you can say, oh, this is most likely a normal beat, just maybe you are just unduly perceiving. But when somebody says it comes and stops, you know there is something. Then you are interested in knowing the mode of onset. If it's just a sudden onset palpitation, most likely it could be due to sinus tachycardia or maybe some serious arrhythmia. But if the onset is gradual and just building up, that one is mainly anxiety, fear, psychosomatization. Then you want also to know how the thing stops, the offset. So palpitation that starts suddenly and also with sudden offset, sinus tachycardia, most of the arrhythmias, especially supraventricular arrhythmia, belongs to that group. And those that start gradually and also goes down gradually are those that are due to psychosomatization,
or they terminate once the person gets busy.
Yes.
Once they get
you just forget
about everything.
Then it will now be important to also ask precipitation. What brings this stuff on? We want to ask about drugs, their state, lifestyle, what they take, so that you'll be able to know, okay, identify what the possible trigger is and what to do about them. Then association symptom, very, very important. This is one of the key symptoms that will help you to know whether this is due to a fatal arrhythmia or underlying heart problem. When patients start having associated history of syncope, chest pain, dizziness, very, you know that, no, I have to be patient and really investigate this person, because what that person is telling you is there is now disruption to cerebral perfusion. So you need to sit down and evaluate this patient. Well, then some of them react polyuria because of the increased release of atrial natriuretic peptide. So they go to toilets more frequently. So that will point to you that, oh, this person may likely be having.
And then some have to relieve it by vagal maneuvers.
Yes. You know, so breath holding, massaging the carotid, so those are also pointer to the fact that this is super arrhythmia that depends on transmission. So doing that slows transmission across the atrioventricular node. So these are some history, and somebody with family history of that has palpitation with family history of sudden deaths, cardiac disease. These are patients that you want to send to specialists
and take
for
time and
review and
evaluate.
take time and evaluate.
So the age of onset is also important, especially those that happen, young.
Yes.
Especially that we have proven in the family that there's young onset cardiac disease. And that means that patients having cardiac disease less than 40, less than 35, less than 40 in their family is quite important. Now, whether it is a true palpitation or it's a symptom simulating it, we see lots of patients that come with chest pain.
Yes.
And they describe chest pain as palpitations or difficulty in breathing.
As palpitation.
And once if you don't divide it, your management will be, you could miss heart failure, you could miss an MI just because you did not take time to clarify what do you really mean by palpitation, because English is hard though. So except they are speaking in their own language, you should take some time to clarify. Then look at physiologic, how does physiologic activities affect it? Does it happen when alone and quiet with thoughts? So you find out a lot of patients will tell you, no, when they get home, they're lying in their bed, they are alone, they are thinking.
Maybe sleeping on your left side.
On their side, they now start feeling it. Does it ever disrupt the activity? They say no. When you are watching a film, do you remember it? They say no. Those are the ones that they are less likely because to be pathological, because it doesn't ever affect when they are busy. So, and then any associated symptoms that Olalekan already said.
Very, very important.
Then over to you.
Yes. This is just elaborating more about what we talked about.
Yes.
Abrupt offset, abrupt termination, like we said, that is telling you that you are dealing likely with arrhythmia above the AV supraventricular tachycardia, so VT. And like I said, gradual onset, gradual termination, benign cause, sinus tachycardia. When it gets better with vagal maneuver, supraventricular arrhythmias, then if it is worse at night, we are dealing with ectopic beats. And this one, apart from this, they are the one that usually feel that heavy tone. Yeah. Because after the ectopic beats, you have a pulse, and you have a large stroke volume. So by the time you have to contract, they feel that heavy tone in the chest, like a blow in the chest. So that's usually common in those people.
If you're just joining us, we are reaching from Cardio Care Hospital in Abuja. We are talking about evaluation of a patient with palpitations and how to go about it so that you can give the patient the very best. And this Cardio Care here in Abuja, Nigeria, and member of Living Hospitals, and we are just great. So about the character, how the patient feels. Some is like a jazz drum, some is like gong. Some is irregular, and some is regular.
Some is like snare drum, just like that fluttering like butterfly. Those on sinus tachycardia, anxiety, and the rest. We talked about those ones that feel that large tone.
Yes.
Those ones are usually due to ectopic beat from premature ventricular complex. Then some people with hyperdynamic circulation
can also feel
toxicosis, anemia, pregnancy.
They just feel continuously.
They can also feel that. Then you have those ones that feel some just irregular beating. Those ones you need to look really into that one. Those ones are arrhythmia, and some of them can actually have some signs in the neck.
Yes.
They call it frog sign, where you see some pulsation in the neck. Those ones are usually due to arrhythmia around the AV node. So we don't want to be blowing all those big arrhythmia here. So that
we have done something on arrhythmia. So if you go to our web page, you can pick up, you can watch any of them, where we went through different kind of arrhythmias and approach to them. So by the time the heart is missing and thumping, you should consider ectopic beat.
So this we just made this a quick thing that you can look at.
When it's was at rest, ectopics. When it's very fast and regular, you should think of SVT and see. When it's sudden onset, so very fast, regular beats could be worrisome. Fast and irregular, we think of AF and atrial flutter. Whenever there is dizziness and there's palpitations, you really want to bring that patient in. Sometimes you need to admit that patient because can be a telltale sign of something very bad happening. And when there's pre-existing heart failure or ischemic heart disease, post-MI,
you need to bring the
patient in. It must be managed by a specialist, and we must, because sudden death is very high in this group of people. So you must approach it in that manner of how it is. Then you talk about radiation, like you talked about.
Radiation to the neck.
Yes.
AV related.
They will feel as if the thing is beating their chest and that they move to their neck. Some of us are used to think that when a patient says something is moving around their body, that it is something in their mind. No, you must take time and first of all assume. So we have cases like complete heart block or PVC. Whenever you have the atrium, pumping against a closed valve, it could truly transmit the waves up in the opposite direction, and you have Canon A waves. I know patients can feel some of these things.
Yes.
And it's quite important to highlight. So what about the other associated symptoms?
So we talked about the patient having syncope, having dizziness, like you said, because at that point, cardiac output is low. And so it's a very, very important symptom we need to ask and we need to take note of. Then patient now having dyspnea before palpitation. Patient may be having heart failure, MI, or patients can have massive pulmonary embolism. So they have chest pain, they have dyspnea before the palpitation. So they can have this same dyspnea after the palpitation. It will also be due to arrhythmia in patients with heart failure. Then patient that has MI or P, they will have chest pain
and they will have palpitation.
They can have palpitation. Then patient can have palpitation and have chest pain, because with palpitation, especially those one that comes with arrhythmia, the diastolic time is very short. So the perfusion of the heart is impaired in itself. Then in patients with mitral valve prolapse, aortic stenosis with very thick myocardium, so they can also have then.
Essentially, when you have associated symptoms with palpitation,
the patient
it is a big red flag
to see. It's one of the indications for inpatient admission and specialist review.
They are having sweating, excessive diaphoresis. You think of an MI, hypoglycemia. Yes, anxiety and cardiomyopathy could be there.
But let somebody find out that all the conditions are not there.
So if a patient calls you now over the phone and tells you or your relative and say they're having palpitations, they are feeling sweaty, they are feeling lightheaded, you need to ask these questions. And they say they're also having some light chest pain too, or breathlessness. You know that you are dealing with something serious. And if you don't address it quickly, what you could hear next is that the person slept and did not wake up.
No, I saw a patient this week that came for evaluation. He came actually from outside the country for his brother's burial.
Oh, yes.
And the complaint the brother had was having some chest pain, some dizziness. And he told him, go to the hospital. And he said, I will go. So he blamed himself because he didn't follow up. And the next call he received, the man collapsed, slumped, and died.
Oh my God. Oh my God.
And died. So those symptoms, as palpitation, dizziness, syncope, please ask the person to go to the hospital.
And that hospital must be fully, an ECG must be done, a full evaluation must be done in that regard. Okay, so the other past history that is important, known heart disease. Because if somebody is having ischemic heart disease or they've been having angina before, that palpitation may be a VT, which may be, telling you that this sudden cardiac death is
like the patient we saw last week, what just prompted us was she had past history of stroke and heart failure. And she came to the clinic for follow-up. The mama was just sitting. So just examination, I palpated the pulse, and the pulse rate was I counted manually, I got about 150. The woman was just sitting. I said, please, mama, before we continue, let's just go and do an ECG. And look, it was SVT. The heart was just running and running. So if not for that past history, we won't even, that suspicion will not even, the level of suspicion will not be high. So anybody with past history of heart disease with palpitation, you should be careful.
And you must take it very seriously. Other drugs, caffeine, alcohol, sympathomimetics, like we talked about, oral salbutamol especially, family history of sudden death is quite important.
Hypertrophic cardiomyopathy.
Exactly. In any member of the family is quite important.
Brugada syndrome.
Yes. So when you're examining, we're looking for whether the heart rate is fast or slow. That one your nurses can pick, If the heart rate is greater than 140 or 130, there's a problem. Once the heart rate is less than 55, there's a problem. There's a problem before we even go anywhere. Whether the person says what, now if they're having chest pain, all those things, you now add them on top. They have hypotension, they have a bounding pulse is irregular, pyrexia, different things like that. This now gives us indication that definitely you are dealing with something very serious And you know, these things, these signs added together makes a strong case for a particular diagnosis, even before you use all the highfalutin tests and the others. Then look for pallor. There's a patient that was sent to me as heart failure or something, and lo and behold, and palpitations, and lo and behold, she has cervical cancer. So I picked it up in my office. I did an examination, saw the mass in the cervix, saw that she had been bleeding also from there and all of that. And then I had to now refer. But she was sent on the basis of anemia. So anemia could have come from other things. And it's important to check all of that. Then, of course, listen to the heart. With practice and listening. A lot of people sit down there, see patients without listening. And if you don't listen, you cannot get better at picking all
these
signs.
S3, S4, whether there's loud P2, crepitations, because sometimes it's just these findings that will make you to go back.
Exactly.
And
ask more questions
yourself that,
and do more tests.
This thing that we have found, why is this? What is the reason? That you cannot retrace and now find out that you have actually, so some of these things may not even be important to the patients.
Yeah.
So it's when you now go back to us that this is very, very, very important.
Okay, so we'll talk about investigations.
Yes.
Generally 12-lead ECG, but just hold on, hang on. We have a full algorithm that can help you sequence your investigations. I will summarize it at the end. ECG must be done. No shortcuts. If you have been enjoying cardio care webinars and you don't have an ECG in your hospital, then you are not, I don't even know what's happening. You are stealing subsidy money. But please and please, an ECG is invaluable. It must be done. There is no shortcut. There is no use of pulse. There is no use of history. After you have done all the things we have said, you must do an ECG.
And if you are lucky to get the patient when the patient is having palpitation, please quickly go and do your ECG. Suspend your history first. Go and do your,
so that you may catch the thing.
Yes, because many of these things are so paroxysmal. Within the next few seconds,
you may miss it.
You may miss it. So if you are lucky, quickly do your ECG and now
while the patient is having the palpitation,
and continue with your history taking.
So the other tests, Holter ECG. Now a Holter ECG is a simple test we could do in cardio care. It is that we put the ECG on the patient and allow him to go home with the machine. He comes back after 24, 48, up to 96 hours, and then we remove it, connect it to the computer, and look at what the ECG has been. The computer will help us analyze all of that, and then we also review it and give a report. So it's a very important test. Blood sugar profile. Also, we have started implanting loop recorder. So that loop recorder, we can implant it, and it can be there for up to 6 months or 1 year. So especially for those that have those things very scarcely, once in 2 weeks, once a month. The last time they had it was 1 month ago. They are not sure that it's very significant. So that is there. And every time they have that thing, we can interrogate and check, get their result even without removing it until after a particular period of time they remove it. So electrolytes is important. Full blood count, complete blood count is important because of anemia, because of all those hematologic issues, and then thyroid function test, very important. For thyroid toxicosis. Now, if someone is having chest pain, of course, biomarkers.
Rule out myocardial
exactly. They have breathlessness, especially SpO2 is going down. D-dimer is important to rule out. PE, echo is very important. Anytime you are suspecting a structural heart disease, even if the patient has high blood pressure and coupled with palpitations, and you have not done an echo, you must do an echo. Now, occasionally we do treadmill exercise testing for palpitations, especially those
that are reduced by
exercise. And I've had a patient, I remember, I did the treadmill exercise and there was nothing until the recovery period. At the recovery period, it just entered atrial flutter for almost 5 minutes and it went down. And that was how we picked it. And we were able to give him appropriate treatment. So this can be very important for managing. So can you take us through the ECG markers?
So if you are very fortunate, because sometimes because of the paroxysmal nature, you will do your rest ECG and you will not find anything. You will not find any abnormal reading, but there are some things that you can still see on your ECG that could still raise your suspicion. But if you are lucky, you can find atrial fibrillation, ectopic beats that you are dealing. But For some people, what you just need to see is to look at the background ECG features you have. So you can see maybe shortened PR interval, delta wave. You know, this one is having Wolf Parkinson White. You can find LVH, left atrial enlargement, which could be substrate for atrial fibrillation. You can, when you say frequent PVC, you know that most likely this is due to ventricular tachycardia and ventricular ectopics. Then K waves, you know, you're dealing with myocardial infarction.
Especially old ones.
Yes, substrate for atrial fibrillation, because those scars in the heart, they are source of.
And also substrate for VT. VT is very, very common in post ischemic heart.
Then when you see wave changes, ventricular hypertrophy, especially in the V1, V2, V3 region, Okum, Brugada ST segment changes, those one will raise your suspicion that what are we dealing with?
If what we are saying is sounding like Greek to you, we have a webinar
on
ECG, which once you listen to it for 90 minutes, you'll be fine. You can read any ECG. So go to our website and then go on our YouTube.
Because if we bring those one in here, we'll make things complex.
We will spend the whole day. So just take time and watch it, and then you'll see how it goes.
Then looking at the QT segment, if the QT is prolonged, you know, this can also predispose to all those fatal ventricular arrhythmias. And if the QT's interval is also shortened, it's also an indication to some fatal arrhythmia and sudden death. And you can also find, like I said, T-wave changes in the V1 to V3, which could be a pointer to arrhythmogenic ventricular disease,
which gives you a very big risk for sudden cardiac death. And really, it is not a good thing for a patient to see you with a complaint and then they say that he died suddenly 2 days after they saw you. No, you should have picked the signs. Don't say that, oh, you don't want to spend patient's money, so you don't do ECG. Even if their burial will be more expensive than that ECG. So do the ECG, do what you need to do. Let the person be the one to say that they don't want to do it or otherwise. So there are these other things. So you get the slide on the ambulatory ECG. There are certain signs that you will see, and the advantages of each of these tests. Can you talk about the advantages and how to choose?
If you are lucky to find a patient having palpitation, whether presently or not, you have to do your 12-lead ECG, like we said, which is very affordable, not expensive. Then, depending on how the frequency of the arrhythmia of the palpitation, so if like a daily or whatever, then your 24, 48 hours Holter will come into play. Which we do here regularly, and it's just for not to make. We have some picture that we can show you that you will see, and you will marvel what is happening in people's hearts. Then, for people that have highly infrequent symptom, then we now talk of implanting,
especially when they're having weekly, monthly,
a loop recorder, which once they have palpitation, they can self-activate, or some of them can record and we can interrogate. And now that we have a lot of cardiac device in situ, they can also do this work for us. Where people having palpitation that have maybe ICD, pacemaker, CRTD, we can interrogate them and see what has happened. And
cardiac care is one of the few places that you can get an implantable loop recorder in the country entirely. Sometimes it can be quite expensive, but the yield is higher, especially when you want to determine, and it's good for more long-term monitoring, you know.
Like one of our team will say that the cost of the loop recorder will be more expensive than the palpitation.
So it's quite costly outside the country everywhere. But we have some support from international agencies which has made it quite affordable. So let us know if your guest needs that.
It's still showing the same Holter monitoring. It will be under the clock. Nobody will know what the person is carrying. Then after 24, 48, 72 hours, we'll bring it back and we'll do the analysis. And it has helped a lot. It has saved lives. So many lives. Even people that you think, oh, let's just do, there'll be nothing. And by the time you see the reading, you will be happy that you have done the test, because you can see fatal arrhythmia that would have killed people. So it's one test that I will not joke with. Once get anybody with, no matter how benign
The palpitation
this palpitation is, I will beg to say, please let us do an alter, because it's also as a way of reassuring even the patients
and the doctor
that there is nothing.
And you know the thing about Holter is not always 100% able to pick all the arrhythmias.
Yes.
But if you can have 48, 24 hours of no significant arrhythmia, to a large extent, it is satisfying.
You know that it is not likely.
It's less likely to develop or to be that, you know. So this is what some of the loop recorders look like. And you can see the picture there too, how it looks on the X-ray. It just planted under the skin. Just very small. It doesn't take up to 15 minutes to put it under the skin, and then it keeps on recording. You know, it has a battery life that can last several years, and we are able to interrogate. Anytime a patient feels any palpitations, they come, they activate the recorder, and then we are able to, you know, interrogate it and pick whatever it is. Okay, so by summary, how we look at it first, what we have said so far is get the history and the examination. Then an echo if you have cardiovascular symptoms or risk factors. And this is from the Society of Family Medicine in Canada. They do a Holter next for frequent palpitations. If the diagnosis is confirmed and the heart is structurally normal ECG, then the management is appropriate. If there's no a problem, then you refer to cardiology. If you have unexplained palpitations, which is structural heart disease or any form of abnormality on ECG, see a cardiologist. And if it is structurally normal heart and ECG and you cannot explain it, still send to cardiologist. Or if you can find maybe other anxiety causes,
you can treat other causes that you can treat, then you may be able to treat.
Okay, so now I want to present to you this algorithm that we typically use here in this place. And what we look at is this: that first, patient comes with palpitations. So that is stage one.
Yes.
Patient has come with palpitations, and then what do you do about that? Next is that you take a history and perform. So number one, take a history, perform physical examination, and get
an ECG.
An ECG. ECG is part of history. ECG is basic.
Yes.
So don't assume that ECG is something big that you know. ECG is a basic test that should be done every time that you know a patient presents in this regard.
And we should not forget, like you said earlier, that the fact that the patient came last week to palpitation and the ECG was normal does not mean that the next presentation you should overlook ECG for that patient. That same woman that we talked about that had the SVT, after discharge, our first outpatient clinic, we did the ECG. It was normal with just occasional ectopics. The following day, she came back with another SVT.
And that is why you must, if you need to do it again and again. So every time you must do it. ECG is not harmful, you know, and it should be done. You should be able to do it again whenever it's needed. So the next step is to do your full blood count, do your electrolytes, including calcium, you know, phosphate, magnesium, quite important. Then TSH to rule out any any thyroid abnormalities. Then screen for drugs where appropriate. And sometimes you could just need to ask.
Yes.
And you need to ask, including eye drops. Don't forget, eye drops sometimes contain a lot of things. Exactly. All of those will be quite important. So you can be treating and treating, not knowing that there's something the patient is taking. Now, the third step is to go on, especially if you suspect a structural heart disease. If you don't suspect a structural heart disease at this point, there's no hypertension, there's no diabetes, person is young, anxious state, other things, ECG was fine, all your examination was fine, your initial tests were fine, you may stop at this point, and then you have diagnosed an extracardiac cause, that's 4A. However, if you suspect that there's something happened, please do an echo and or a Holter ECG. And so at this point in time, referral is very, very much
very important. So because you may not have that echo, you may not have that Holter, and we've talked about pointers, things that will point to underlying structural disease, family history of sudden death, past history of heart disease, when the duration of the arrhythmia is prolonged. when patients, elderly patient, older age,
associated symptoms.
Yes.
Patient with hypertension or diabetes,
syncope, dizziness, chest pain, difficulty with breathing.
All of them.
All these ones must have an echo.
So typically at that point in time, that's 4B. You're looking at 4B on your algorithm. Refer to cardiac care hospital or other cardiologists. So for a full monitoring. Now, if it's daily or quite frequent palpitations, then we want to do a Holter. That is 5A. But if it is less frequent, less than daily, maybe once in a week or otherwise, you may want to consider event monitoring. That's the loop recorder we talked about. So now, what do we do next? We now have 4 options, which is number 6. Number 1, on review of your Holter or your loop, you could have the patient say that I had palpitation. But when you look at it, it was normal. So in that kind of case, you reassure the patient, except there is a structural disease. If there's a structural heart disease and the ECG is and the Holter is normal, you must still treat whatever the structural heart disease. So
definitely,
if the patient has hypertensive heart disease, you must treat. If they have left ventricular hypertrophy, you must treat. If they have a heart failure, you must treat. Even though the Holter is normal, you must treat that heart failure. Okay, so next is if they find PVCs, multiple PVCs on the Holter. Now, we will not bore you with this, but we typically grade it using the Lowndes grading system. Okay, and it's quite easy to do. When we look at that, round grade 1 to 2, especially if there's no structural disease, we typically reassure, except there's a structural disease that indicates treatment. 3 to 5, whether there's structural disease or not, we typically have to treat and put some treatment. Okay,
so definitely this patient must be a specialist.
Of course, please and please. And one of the good things about if you send to us, we'll communicate with you, put your phone number, and you get our number put on the screen, which will be on the screen at the end of the presentation. And then we can talk over and send you reports about your patient from time to time. Now, if you do it now and you find a non-ventricular arrhythmia, that could be AF, that could be flutter, SVT, could be intermittent, you need to still treat, but you may not be as aggressive. Now, if you find a ventricular arrhythmia, ventricular arrhythmias almost always portend, especially when they are significant or sustained. A sustained ventricular arrhythmia is one that lasts more than 30 seconds.
Yes, sir.
So if it's having it sustained ventricular arrhythmia more than 30 seconds, the risk of sudden death is extremely high. And those ones you need to treat. And in some cases, you have to go to number 8, which is to put in a device. So that where the medication is able to do, the device is able to analyze and treat and terminate the so it's as if a doctor or a guardian angel, just like Ericsson, the Man United footballer has. He has one in his chest. So when he's playing football, somebody is checking his ECG, and if something goes wrong, it treats him immediately. So in these cases, you need to treat. So again, when we have found that a patient has structural heart disease or we suspect, if we see normal sinus rhythm with palpitations, we just reassure, except the structural disease. If we see Lowndes grade 1 to 2 PVCs, we reassure. 3 to 5 or non-ventricular arrhythmias or ventricular arrhythmias, we must treat. Now, there are patients that need, especially when they need criteria for pacemakers, for ICDs, or when they need CRT. We typically use CRT if a patient needs an ICD and has heart failure, and the QRS duration is wide. So those patients refer to cardiac care for the device. And if they have an existing device and they're having palpitations, you also still need to refer to us because we have the programmer for most of the northern region, so that we can reprogram, evaluate that device. And that device can act like a Holter, really.
Yes.
It acts like a loop recorder because it will give us
what is
exactly.
So by the time we interrogate, we know what is happening.
It will tell us what has been happening for periods of time, and we can know what to do typically to adjust treatment. Now, remember the 4A, the ones that we found a definite extracardiac cause, and for whom we've been able to exclude a structural heart disease. Yes. So some of these people coming with anxiety, they have an extracardiac cause, fine. However, we must still exclude a cardiac cause. So when we have excluded that, before we settle the matter, then we can now treat anxiety, treat thyroid, treat drugs,
infection,
anemia, or whatever. So with this algorithm, the patient coming to you with palpitations, if you reward the video and go through it, and this algorithm, you should be able to use that and manage successfully.
Okay, let me follow this
based
on what you are. And you will know when to send the patient to the next level. So by step 3 or 4, the patient should be considering
specialist referral to a hospital with a cardiologist, or you can send to cardio care hospital, where we can do a thorough evaluation of all the things that we've talked about today. Okay, and so patients with frequent arrhythmia must be referred. Patients with associated symptoms, family history of this must be referred. Significant echo
or echo abnormality,
they must be referred. You know, all of these patients must be referred. And the treatment, essentially, the treatment of different arrhythmias are different. So we will not go into that one.
Details of each one.
But whatever cause is found must be treated.
It's important.
What about psychiatric causes?
So that's where once you have identified that, oh, there's an underlying psychiatric issue to be dealt with, the psychiatrist must be called in, whether they want to do therapy, whether it's just cognitive therapy, whether it's just counseling, that must be done. Because if you don't do that, the patient will still comes back.
And some of our patients need to add anxiolytics, even in addition to the beta blocker, because people can be very, very afraid, even while you are treating their current disease. So we need to reduce the anxiety, because anxiety will fuel sympathetic discharge and
just have that vicious cycle going on and on. And like you said, when we're looking at 4A, we have exclude. We've been able to exclude cardiac causes and whatever.
Exactly.
All we need will not be more than reassuring the patient that we have done all this. There is no underlying cardiac problem. Your heart rhythm is fine. So reassurance goes a long way. The lifestyle of the patient, someone taking a load of coffee, caffeine, energy drink, they need to do a lot of
manpower, different things, including green tea.
Including
green tea. A lot of green tea has a lot of theophylline in it, and those could also trigger cola nuts, bitter cola. You know, you need to take some time and advise your
a lot of Coke.
Coke, yes,
has a lot of caffeine.
Yeah, so
sorry, we are not doing marketing.
Coke, please sponsor us still. So those are some of the key things that you need to watch out for. So if you have any questions, put in the chat box and we will attend to them. These are some references which you can check. Again, quick announcement is that we will send the slides to you. Please share with your friends and family. But remember that whenever you are using the slides, try to give credit to whom it is due. This is how you can refer or partner with us here in Abuja. You can call any of the numbers that you are seeing on the screen to refer or partner with us, or send a mail and we'll attend to your patients promptly, or give them a referral letter, and that's how you can reach out to Cardio Care Hospital. We also have done over 500 successful interventional cardiology cases, from pacemakers, from interventions, ICDs. We've done quite a number, CRTs, IVC filters, anything that involves the heart, cardio care. Now we are starting our cardiac surgery program. So if you have patients that need cardiac surgery, these are also available. Anytime you send your patients, you can always talk with us. We'll give you good referral. Please enter our WhatsApp group. If you have further questions after this, or you have particular cases after this, what our simple rule is, whatever question you put a suggested answer, then we'll now try and correct you. So join our WhatsApp group where we can also discuss from time to time, and then we'll give you all of these things. So these are some things about cardio care. I will show you some interventions, a video on certain interventions that will tell you some of the things that are very possible here in this country, and which we have been doing here in cardio care, and which will likely be of benefit to some of your patients. And while we are doing that, I will be reading the questions. Peripheral angiography and angioplasty. So essentially, sometimes people have patients with forming gangrene or not getting enough blood flow to the legs, pain, especially diabetics, and it's very important for us to be able to address that. Put a stent where it is blocked, and you can see now where was blocked now is now opened up with very good supply, and that saves somebody from being amputated. So we want to save legs as much as possible. You can see the before and the after, and that patient could have been amputated in previous times. So that's quite important to note. We also, a lot of patients come with heart attacks, chest pain. This is how we do it. Simple puncture to the femoral artery or the radial artery, and we're able to do this in less than an hour. We see where the blockages are on the blood vessel. In this case, this is the circumflex vessel at the OM. And then after that, we put in a wire and put in the stents. And you can see that place that was blocked is now opened up. And this patient's chest pain will significantly get better, including patients having palpitation because of ischemic heart disease. So these are some things that are very important, and it's done here in cardio care. And we are happy to support work that is being done by all of us in our different centers. This is a case of a patient with a renal artery occlusion, 100% occlusion of the renal artery, had severe abdominal pain, acute abdomen, did a CT angio and was able to pick it up, and they sent it from out of town. Yes, and then he rushed in. As soon as they came in, we were able to do a procedure called the CDTT, macerate the clots, and then open up the blood flow, and the patient was able to go home the next day. So it's a very important renal artery angiography intervention. That if not, that person's kidney will be gone, and before you know it, you are looking for kidney transplant. And sometimes in massive pulmonary embolism, we talked about pulmonary embolism as being one of the causes and you can see that massive clot that has stopped blood flow completely to the left lung, completely. And if you look, you can see afterwards, after the procedure, now that place that did not have any blood flow now has blood flow. And right on the table, we can see improvement in the oxygen, the amount of oxygen the person needs, very, very important. And this can be very important in patients with pulmonary embolism. Yes, it's not particularly cheap, but it's very important and life-saving. Then we have pacemakers, ICDs. Now, for patients presenting with palpitations, for whom they have either they've had MI or their ejection fraction is low, or they have documented VT, we typically have to put in a defibrillator. It's a small device like a pacemaker under the skin, and it just helps to prolong life. It can prolong life as long as 7 to 10 years. That is how important this device is, and we have lots of patients on it that come for follow-up with it. And also for those that now have heart failure, we may now go ahead and put a cardiac resuscitation therapy device, which goes beyond just defibrillating and identifying abnormal rhythms. It also helps to coordinate
the activity of both
sides of the heart, and so that's very important. And this is a cardiac. So this one, the coronary sinus around the left, this one the right, and this one is the right atrium. Now you can see this thick black area. That thick black area is the shocking coil. So in case the patient needs to have a shock to bring them back to life, those two coils, this thick black area on the wires, will allow the device to deliver a shock and stop the person from dying. And so those are some of the things that we do commonly here. In addition, neurology, nephrology, critical care, endo, rheuma, so anything internal medicine, and very important to reverse medical tourism here in Nigeria. And I'm happy that all of us could join up today. We also have residency training and partnerships with different universities, and we are happy to support with conferences and symposia. This year, at the end of the year, we're having our 6th or 7th Abuja Cardiovascular Symposium, and you need to be here. Plan for it. 7th, right? The 7th Abuja. So we have done that every year, and it's a fantastic time. So plan to be here. We do lots of hands-on basic life support. So plan now and start preparing for it. We have started kidney transplantation. We had a very successful kidney transplantation last week, and we have started and we are ready to do that now. So people don't have to go abroad or get into trouble in different places. So very important for us. And cardiac surgeries are now available all year round. So beyond teaching, there's some work that we are doing also on the ground, and our children's hospital is also doing lots of work, and we are happy to have you. So we'll take some of the questions that may be in the chat box. Let me see. Question. Please, I hope we entered late. Okay, so recording will be available. We'll send you the link to the email that you registered with, so that you can watch the whole thing. But you can also go to our website after by Tuesday, cardiocare.ng/webinars or to our YouTube page, and then you can get that. And thank you, Dr. Musa Shoaibu. Thank you so much. Thank you so much. Rashida Zakaria, you say thank you very much for the presentation. Please, can you comment on pulsatile tinnitus? Dr. Olalekan, pulsatile tinnitus. So,
this will be in the realm of the ENT.
Exactly.
So I think maybe people
hearing
their heartbeats, like we say, many of it is due to like exaggerated awareness of normal heartbeats. And
still, you will still follow the same algorithm. You will still do an ECG exclude
before you say that is. So, like we said, by the time people lie on their left side at night, quiet environment, you can hear that. But like we said, please make sure that you have fully evaluated the patient before you say, oh, there is nothing. Because like we say, for almost 50% of these people, there may be an underlying issue.
Exactly. So
palpitation can also be assisted with pregnancy.
What's the management? So typically in palpitation in pregnancy is also similar. Of course, you must exclude anemia in pregnancy.
Yes.
Remember that pregnancy is a hyperdynamic state. And so sometimes they have increased, they are feeling all of those things. Still, you follow the same algorithm. We have had patients with life-threatening VT in pregnancy.
Yes.
I know you remember that woman. Exactly. So you cannot assume because it could be seriously, so still follow the algorithm. When you have excluded cardiac causes and you have done an ECG and it is fine, and there's no reason to suspect otherwise, then you can now counsel. Occasionally, it may be so severe, they may need to do a Holter, and occasionally it may be so severe that they need medications for treatment. Yes. That same algorithm tells you who needs treatment or not, and at what time. So there are patients that in pregnancy we diagnose for the first time a congenital heart disease. And so some of those things are important to get treatment and specialist treatment at that point in time. Okay.
Palpitation in a pregnant woman, will I still follow this? Yes, it works for everybody.
It works for everybody. Okay, so I love taking coffee on a daily basis. Can this affect me in future? So coffee and palpitations, it depends on the individual. Different people relate to coffee differently. Of course, coffee is drank by a lot of the West, yes, and most of them don't have any issues, and I don't think there's any long-term study to show any abnormality.
It is controversial.
Yes, so
the issue with coffee. But if you know you take coffee and you have palpitation,
you have to stop. You have to reevaluate. So otherwise, if you don't have any problem with it, please, I don't think there's any problem as of now based on the existing literature. Okay, so ECG reading and interpretation is difficult for me. So like I said, just go to our platform, our WhatsApp platform. If you have a question, ask on there, but go to our YouTube page. We have explained ECG in the easiest way a Nigerian doctor can understand.
And if the person can also come for the Abuja Cardiologist.
Yes, and if you come for the Abuja Cardiologist, the first week of December in Abuja, I promise you, you read an ECG. You read ECG. So please, sir, there are some things a patient with palpitation needs to avoid, such as food and activities. Okay, so are there some things you need to avoid? We talked about them: bitter cola, Coca-Cola sometimes, things that contain caffeine, stimulants, including wee-wee. You need to ask, you need to ask about that. You need to ask about Red Bull, Power Horse. People take lots of things as sexually enhancing drugs. You need to check about them. And
drugs taken for asthma.
Drugs taken for asthma. Exactly. Yes, then all the cold medications too, they also cause it, and a lot of the eye drops. So you need to go through a detailed drug history to clarify all of that. With that, I think we've answered all the questions. If you have more questions,
I don't think there's anything in the chat box.
I don't think there's anything. So you can just send to our email address, or you can, when you log into our WhatsApp group, we'll gladly assist you in one way or the other. Tomorrow morning, we have Abuja Health Walk here in Abuja, in central area. So if you can meet us by 7 a.m. We'll also teach CPR, cardiopulmonary resuscitation, how to resuscitate somebody that has collapsed. We'll teach it in a very basic and easy way. So if you can join us 7 a.m., let's practice what we preach. We exercise, we'll check our blood pressure, then we'll do a CPR training for the public, and it's very important that you join us as well. Chris Matiluku raised his hand. Okay, let's just allow. Chris, you can unmute yourself and talk if that was not a mistake.
Good evening and thank you for the presentation.
Yes.
Sorry, I had to raise my hand. I've been trying to write in my question, but I couldn't. Please, I need the WhatsApp number, if possible, to be displayed, or will it be sent to us on our email? I want to appreciate for this wonderful lecture. It's very eye-opening, and I hope I can always join each time it comes up. Most times I'm always very engaged at work, but today I had to just make time because of the important topic of palpitation. Thank you very much. Very elucidating, and we are grateful for what you are doing. Thank you, sir.
The number was in the chat box.
So with that number, you can join the WhatsApp group.
Just send a message to that phone number and you'll be added to the WhatsApp group so that you can easily partner with us at any time. All right. So thank you. And NEPA is trying to tell us that it's time. So we also agree with them. Thank you so much. And you can rewatch it again and you have access to the slides also later. Thank you for joining us. And we look forward to hearing from you, meeting you. Whenever you're in Abuja, stop by, say hello, tell them you've joined us. Let us be happy to meet you. And then refer your patients where necessary so that we can partner and make Nigeria better. God bless you all. Have a lovely weekend. See you next month by God's grace for another exciting time. So look out in your emails and your text messages to join up. And please invite others. Invite people from your class, from your chat group, from everywhere. Invite them so that we can have a great time improving Nigerian healthcare.
I can see some of my teachers on the,
whoa.
Dr. Fashaye, I saw his name.
Wow.
So thank you for joining.
Thank you for joining. I can see Dr. Olalekan. Thank you for joining. That's my classmate. Who else can I recognize now among these names? Dr. Miriam Keshiro. Nice to see you, Ma. She taught me pediatrics. Dr. Ola Golden, thank you so much for joining us, sir. Let me see if there's any other person I can recognize. Yeah. I think that's all I can recognize. Dr. Sulaja. Yes, thank you for coming.
Thank you for joining. God bless you.
I'm sure you had a great time. So thank you very much, everybody, and have a lovely weekend. Again, if you check the chat box, you can send a WhatsApp to that number in the chat box, and you can be added to the WhatsApp group.